Greetings of the day, everyone. I am Kritika Saxena and I'm a clinical psychologist. You would ask who a clinical psychologist is. A psychologist who is specialized in seeing clients or patients of clinical disorders. Clinical disorders such as depression, anxiety, OCD, dissociation, schizophrenia, bipolar. These patients who require either an admission, which is an inpatient treatment, or they require treatment intervention on an OPD basis, which is an outpatient basis. Now, when you see a client or a patient, I would use those words interchangeably here. When you see the client first, the most important or the most significant aspect is history taking and MSC. MSC, which is mental status examination. And those two are the topics for today. Let's understand why is it so important for us to have an elaborated, explorative case history and MSC. There would obviously be a lot that the client would come to you with their complaints, would like to tell you. But you, as a professional or an expert, the psychologist or even a psychiatrist, if you do not have a certain structure to your interview, the correct or the proper questions, you would not be able to elicit the information that is going to be crucial for your diagnosis and from your diagnosis leading up to your treatment plan. Let's start. So like I said, that a case history, it's a record of the client's life. That where do they come from? What has brought them in here today? What are they planning ahead in life? What are the current challenges that they are facing? What are the current concerns that they are facing? And this has to mostly be in their own language, in their own words, from their point of view. Sometimes you would also see that a patient is accompanied by a significant family member or a guardian or a friend. We call them an informant. So adding to the primary client who has come to you with those concerns, there can also be an informant who is giving you the case history. The case history questions can be asked both to the client as well as the informant. Now this includes the purpose, the diagnosis, and how to formulate a specific and effective treatment plan. Like I was saying, that why it is so important for us to have a good case history is to be able to really understand the concerns of the client, to be able to make a diagnosis, and therefore make a treatment plan. You have to understand that treatment plans or interventions, whether they are in psychiatry, which is medicine based, or in psychology, which is more therapy oriented, a therapeutic intervention. Both these kind of interventions, they require either a psychiatrist or a psychologist, and both of them are tailor-made. When I say tailor-made, I mean that it has to be specific to the client. The same medicine or the same treatment module or the same therapy is not going to work upon all the clients. So you have to tailor make it according to their requirements. So you have to allow the client to talk as much as they can on their own, using their own words, explaining their own perspective. In between, you ask relevant questions wherever you feel is appropriate, such as drawing a timeline or eliciting more and more chief complaints. The aim is to derive a comprehensive picture so that we are able to understand the individual, its environment, and the causes leading up to their discomfort. Here are a broad components of case history, starting with the socio-demographic details, followed by the chief complaints, followed by a history of the presenting illness, which incorporates the onset of the illness and the precipitating factors. We'll dwell more into them elaborately in the further slides. The history of past illness, if there was a past illness in fact, whether it was psychiatric or medical. A personal history which goes back to their prenatal and birth history, their social history, substance use or abuse, a family history, and a pre-morbid personality. A pre-morbid personality is the personality that the individual had before developing the illness. Let's start with the first one, which is identifying data or socio-demographic data. Now this gives us a summary of where the individual is coming from, what their age is, what their gender is, what their sex is, as a lot of you would be recognizing now that sex and gender are two completely different things. Sex is your assigned biological characteristics, whereas gender is how you identify yourself as. So you need to remember that in your practice, in your case history taking, this is something that you are specifically clear about. More such details about the individual name, their marital status, gender, sex, age, their occupation, are they working currently, are they a student, their ethnic background, where are they coming from, they could be living in a different city but hailing from a different one altogether, their religious beliefs, their languages known. Sometimes it's very important to know what is the language that the individual is comfortable with. You as a professional would want to maybe communicate in English or Hindi or maybe your regional language, but the individual might not be comfortable with that. So it's very important because all your history is based upon this verbal dialogue. Coming to the chief complaints. Now these chief complaints or the concerns are what the first patient expresses, in the sense that something happened and that is what brought me here. Or that day that happened, it made me feel this way, and then they came to see you. Or something of grave nature has impacted them and is causing them discomfort, and that is why they have come to you. Those accompanying the patient might also give their own perspective, which is the informants like I had told you, and that is okay. The perspectives don't need to match. These are just chief complaints. We are trying to understand what has brought the client and the informant in. Certain questions that you can ask when you're sitting with the client first is, what brings you here? Or what is it that caused you to come to the hospital or the clinic or any space that you're occupying? Have you been having any problems? Can you tell me more about them? When did they start? How did it develop? How does it make you feel right now? Moving on, when you have the chief complaints, which would be anywhere from 5 to 7 in number, because those are mostly the symptoms that we are talking about. Moving forward, you try and go back further into the history to see where did they first start happening. So, a history of present illness, commonly also called as HOPI, is a chronological timeline of events and incidents leading up to the current moment. This is the most helpful in making the diagnosis, because sometimes you will see in clinical disorders that the diagnostic criteria in itself is based upon the duration of the symptoms. So some symptoms, similar symptoms over a period of short time can have a different diagnosis, whereas the same symptoms for a prolonged period of time could have a completely different diagnosis. That is why it is very important for us to establish this timeline. What it further includes, the onset. Onset meaning whether it was sudden, whether it was acute, whether it was insidious or chronic. Has it been long going and gradually it built up, or just suddenly one day the client started having those symptoms. Then the immediate precipitating events or triggers. Did an incident or an event happen recently which caused the client to feel that discomfort? The progression of the illness, which is the symptoms are more or less stable or they're deteriorating, sometimes they fluctuate up and down, or it is episodic, that you have the symptoms and then you're completely fine and then you again have them and then you're completely fine, or improving, in which case that when the first time that you had the symptoms, from then till now, it has been progressively getting better. Then what were the exacerbating or the relieving factors, which means that something that helped you come out of that discomfort, if at all, even for a shorter period of time. And what is the kind of impact that those symptoms have had on your personal, interpersonal and occupational life. Now symptoms, they have to be summarized in a chronological timeline, like I said, and that should highlight the significant events in the history with the onset, with how it progressed, what the course was. All complaints mentioned in the chief complaint should be present in the history of present illness or HOPI, like I mentioned. So again and again I'm going to reiterate that your symptoms, if we imagine them to be here, we are going back and seeing the history where it first started, and it has to lead up to the current symptomology or the current symptoms that the patient is going through. Some questions that you can ask them is, how did this all begin? Any specific events or incidents that you remember around that time? And what was the difference that you noticed in your behavior? Did you feel any different? Did you started feeling differently? Moving on, the next one is history of past illness. So it might not be so that there has been any significant past illness, whether psychiatric or medical, but it is important that you ask or you elicit this from the individual just for clarity. Now this includes both psychiatric and medical illnesses, like I said, and it serves as a transition period from the history of present illness and the patient's personal history. So there would have been again a time when there were no symptoms, and then there was an illness, treatment was done or not done, and the symptoms settled by themselves. And then again there was a period where the patient touched their baseline. Baseline is every individual's own line of normalcy. Because like we say in psychology that there is no one normal, there is no absolute. Every individual has their own baseline. And then from the baseline, the symptoms can go up or down. So as I was mentioning, there was a baseline, incident happened or the disorder happened, treatment was given, not given, and it was resolved and you were in your baseline again. And then maybe the current scenario has happened, the current illness has happened. So it also helps us in establishing the previous personal history of the patient. What the past psychiatric history could look like is you ask about the psychiatric illness, any symptoms, had they contacted any professional at that time, did they seek treatment, what was the response like, or did it need hospitalization, which is your inpatient treatment? Were they treated by a professional who is an expert, like a psychiatrist, a psychologist, or was it managed by any other doctor, such as a general physician? The questions could look like any similar or other psychiatric problems in the past, or what treatments have you had previously? A past medical history could be your any biological or medical ailments, disorders, illnesses. This could be anything related to your digestive system, your nervous system, maybe even any blood workup, anything that you felt was biologically or medically not in concordance with your body. Again, the history taking would include the symptoms that you felt, whether or not you went to see a doctor for it, did it get better, what was the treatment like, did it worsen, is it better now, were there any side effects? That's also a very important question. I think with asking the medical history, it's also important that you ask their life conditions. A lot of times people might have hypo or hyperthyroidism or diabetes 1 or 2 or maybe blood pressure high or low. And why that is important to know is that how that fits also into the current scenario. It is also important for the psychiatrist to know so that they can prescribe their medication accordingly. Now, more of past medical history. Other significant illnesses could be, like I said, neurological, surgical, cardiac, and all of these questions should be asked because maybe the client misses out on expressing that or mentioning that, but you as a professional, because you have a structured interview in mind, you should be able to elicit these responses from the client. Coming next to family history, which includes the socio-demographic details of the family members, which can go up to 3 generations. Why we prefer that the family history be elicited for 3 generations is because when gene studies are done, we see that certain genes are expressed in the generation, it skips a generation. So maybe sometimes what the grandparents had, it could only be expressed in the grandkids and it has skipped that generation of the parents. It's important that we take history for 3 generations and also important to take that history from both sides of the family, which is that of the father and that of the mother. It is important to note if at all there are members who are deceased and what were the causes for that. It is also important to know that if any of them had any psychiatric illness, whether undiagnosed or diagnosed, if diagnosed, and what was the treatment for that. Because it is seen that a lot of mental disorders, mental health illnesses have a gene specific to that illness, and that is why it is hereditary as well. Now, a brief statement of psychiatric illness treatment. If any immediate family member has expressed any such concerns, that needs to be noted. Also, what we need to ask along with family history of medical or psychiatric illnesses is the current family environment, the kind of relationships that the client shares with the family, who is close, who's aloof, what is the current living situation, who does the client live with, how many siblings do they have, whether they're coming from a broken home or their parents are living together, has any one of them been remarried, what the siblings also have gone through in their own individual lives. Like I mentioned, the cause of death or deceased family member should also be mentioned. Now, the role of patient's illness in the family is also to be discussed, and the questions can look like, how has your family responded to your illness? What does your family feel about your illness? Are they able to understand the problems you experience? Have they tried to help you? If so, what have they been able to do this far? When you are coming to the OPD or for an admission in the IPD, are you coming by yourself? Is your family accompanying you? So as you would know that socio-culturally, family plays a very, very important role in our life. It's our first response support system, and it makes for a major part of our ecosystem. That is why it is crucial to understand the family dynamics, the communication, the understanding about the mental illness, their receptivity, how far are they willing to go along with the client in this journey of recovery, so that in that manner the rehabilitation of the client can also be planned. Coming next to the personal history. Now this goes back to the prenatal and the birth history, which includes details of birth, early development, which are all the crucial milestones. When did they start sitting? When did they start walking, talking, use of one word, two words? When were they able to dress themselves? When did they become independent completely, not relying on any other person for clothing, food, sitting, walking, having water from a cup? Those are all your early developmental stages. About their childhood, what were their peers like, what were their play activities like, how was their education, how much attention was there at school, or were they notorious, what was their peer group like. All of this comes in the early birth prenatal history. More from personal history is then occupation. If suppose the individual coming to you is a young adult, a 24 or a 25-year-old, it is important to understand, are they still studying, are they done with their education, are they currently working or pursuing a course. If they are in fact in an occupation, it becomes important to understand the team dynamics. Are they a team player? What is their communication pattern like? How do they feel at work? What is their job satisfaction level? Because again, every information accounts and collaborates with the current state of discomfort or concerns that the client has come with. Furthermore, in the personal history is the marital and psychosexual history. If they are married, for how long have they been married? Was it an arranged or a love marriage? What is the family pattern like? Are they living in a nuclear setup? Are they living in a joint family setup? How has that impacted them? The psychosexual history is going back to their puberty. How did that evolve? How did they take it? Did they discuss it at home? Did they discuss it with their peers? And lastly, the substance use and legal history, if at all, which has been present. The kind of substance, for how long they have been consuming it for, how does it impact their body and mind. And legal or forensic history, if there has been any altercation with the law. This is something that I've fairly gone over with. Coming to a closing part, which is pre-morbid personality. This is the last aspect of case history, which is to understand that before the illness happened, how the individual was. Some questions that you ask them: before all this happened, what kind of a person were you? How would you describe yourself? How would your friends describe you? How would your family describe you? Or you are in this discomfort right now, but let's say if you were in comfort previously, how would you define yourself? That's all for case history.